from? Oh, yeah.
Yeah, so everyone get yourself in focus. For those joining us remotely, we are doing adnexal, which is mainly alopecia, but not all alopecia. Tell me when you guys are in.
Yes.
Yes.
You good? Okay. So, Lisa, you wanna start us off?
Sure. So, it looks like we have kind of varying diameters.
Yes.
Hair follicles.
So if you were looking at a blood smear, you would say anisocytosis, right? So this is anisotrichosis, big circles, little circles. And so give me two things that give you varying hair shaft diameters or hair follicle diameters.
Pattern, and I think alopecia areata.
Yeah, so pattern and alopecia areata are the two. And so then you want to look down towards the bulb, and what kind of things would be clues to AA in the bulb region?
So eosinophils, inflammation around the bulb, so lymphs, eos.
Yeah, lymphs, eos, pigment, those would be the big things. The other thing, anything in the outer root sheath that would be a clue to alopecia areata? Tend to get lots of catagens.
Okay.
Especially in early AA, not in late, long-standing AA, but early AA you get lots of catagen hairs. So that can be a clue. In fact, name three things that give you lots of catagen hairs.
Alopecia areata, trichotillomania, and Louise.
Yep. So syphilis, trichotil, and AA tend to give you lots of catagens. Here you've got occasional catagens, right? So catagens are marked by dead red keratinocytes in the outer root sheath. So if you've got outer root sheath cells that are dying, undergoing programmed cell death, do you think, this is a trick question, if there are lots of cells dying, is it A, growing outer root sheath, or B, a shrinking outer root sheath? Shrinking, which is kind of what defines catagen, right? So catagen, you've got shrinking outer root sheath, defined by lots of catagen hairs. So for alopecia, sometimes you look for intersecting lists of differential, right? Here you got miniaturization, that could be pattern or could be AA. Don't see pigment, don't see eos, don't see inflammatory cells, but do have some catagen hairs. So would still keep both of those in my differential. Okay. Okay. So, Ahmed, what do you see?
I see suppurative inflammation around the level of...
So there's definitely suppurative up high. And what part of the hair is it attacking? This is a tricky one. Is it the deep part or the superficial part of the hair follicle?
Superficial part.
Which we call the
infundibulum.
Infundibulum. So this is something attacking the infundibulum, right? And what kind, you said there's suppurative on the top, there's crust and suppurative, and then what are all of these cells?
They look like pituitary histiocytes.
They're histiocytes, right? So those are lymphs. So these gray things with vesicular nuclei are histiocytes. So tell me something that makes histiocytes beat on the infundibulum of hair follicles.
LGH. LCH.
LCH, Langerhans cell histiocytosis, correct. So LCH, Langerhans cell histiocytosis, is where histiocytes beat up on the infundibulum of the hair follicle. So it's a scan diagnosis, and if you're waiting to see reniform nuclei, you will never make the diagnosis, right? So we're going through the unknowns, which especially for alopecia, because they're it's a little different from some of the other topics that we hit. we'll go through that, and then we'll go through some lightning rounds. Okay, so
Matt?
sure,
All right.
you get to pass or play. What do you want to do?
No, I'll play.
Okay. So what are we looking at?
A hair shape?
A hair, yes. And tell me what happened to this end of the hair.
It was plucked.
It got a haircut,
Right. Okay.
right? So that's, it's cut as with barbers, scissors, right? So that's a normal cut hair. So now we're looking at the other end. And tell me about the other end of this hair.
It appears to be tapered.
It's tapered and it loses its pigment, right?
Mm-hmm.
So a tapered fracture is characteristic of what kind of things?
Tapered fracture.
So first off, does that go with A, telogen effluvium, B, anagen effluvium?
Anagen.
Anagen effluvium, correct. Very good. It's always the second one, by the way. So it goes with anagen effluvium, right? And so causes of anagen effluvium. Anyone want to pipe up?
Chemotherapy.
So chemo would be one, right? And the history would probably be helpful. So anagen effluvium, tapered fracture is just like a Bow's line in the nail, right?
Okay.
So chemo would be one. What else? What's the most common?
Crash diving?
No, that's more telogen effluvium. So alopecia areata is by far the most common, right? So chemo is a toxic insult to the matrix. Alopecia areata is an inflammatory insult to the matrix. Both of them cause shutdown of hair fiber production, and you end up with a tapered fracture, right? So if alopecia areata can do it, then what else can do it? Syphilis. So if you've got someone with the moth-eaten alopecia of syphilis and you look at their hair shafts, they have tapered fractures, right? Just like alopecia areata. So AA, syphilis, chemo, and then what other toxic ingestion is right up there?
Heavy metals. Thallium.
Heavy metals with thallium being at the top. So we had a gentleman, I guess it was 2 years ago. He was one of 36 people to present with alopecia areata simultaneously after they were doing a cleanup of an electroplating factory after a flood. And guess what they use a lot of in electroplating? Thallium, right? So, that's kind of a classic. You see clusters of people who look like they have AA. It's a marker for thallium poisoning, right? So, okay, very good. Keep on going. Okay, how about this one?
I see a punch biopsy with inflammation kind of along the hair follicle and deep.
Yeah, so inflammation's kind of everywhere, maybe heavier deep than superficial, but kind of everywhere.
Mm-hmm.
And then anything going on in the follicle?
I see mucin right there, and so alopecia mucinosa,
Yeah.
and sometimes that's
So there's
associated.
follicular mucinosis, and then what you're alluding to is follicular mucinosis comes in two flavors, with or without
mycosis fungoides.
mycosis fungoides, right? So when you see follicular mucinosis, the question is this benign alopecia mucinosa, which is usually a younger person, a boggy red plaque,
Okay.
looks a little like a carrion, right? Like a fungal carrion. Or if it's an older person with large poikilodermatous patches, that's probably MF, right? And honestly, unless you see a lot of atypia, the clinical tends to be more predictive of outcome than any marker or anything you can do with the path, right? Once it becomes very atypical, it's declared itself. But early alopecia mucinosa, its course is probably better defined by the clinical presentation. So young person, boggy plaque, likely not to be MF. Older person, more widespread, bigger than your palm, limb girdle area. Poikilodermatous over time is likely to be MF. Okay. And, all of this blue stringy stuff is mucin. So when you see that, then it's not hard to make the diagnosis. That's one of my best ones. I'm here all week. Okay.
Okay, so I see a hair follicle filled with like keratin debris.
Yeah, so a big dilated hair follicle.
Suppurative inflammation.
Yep, so what are we probably looking at?
It looks like acne.
A zit, right? So acne starts with follicular hyperkeratosis, retention of keratin, and then there's secondary overgrowth of bacteria and inflammation, and but the primary pathogenesis is a retention hyperkeratosis, which is why retinoids are so key to the management. Okay, let's go a little faster.
Controversy.
Yep.
Very dense infiltrate.
Very dense infiltrate, and you said lymphoid. Are you going to stick with lymphoid, or is it more polymorphous?
Polymorphous. It has.
It's got a little bit of everything. It's got newts, it's got eos, it's got limbs. Sort of all hell has broken loose. And that often goes with what?
Often goes with fungus.
Yeah, exactly. So you see an endothrix fungus. So this is fungal endothrix, whether it's a carrion or Miyake granuloma, it looks pretty much the same.
Inflammation around the bulb.
Inflammation around the bulb, and is it lymphoid or suppurative?
What's lymphoid?
Lymphoid. So tell me things that can give you lymphoid inflammation around the bulb.
Alopecia areata or syphilis.
Alopecia areata or syphilis, correct. And they pretty much look identical. And then if you look here, there are all of these little hairs that are kind of twisty-turny and have lots of apoptotic cells, so those are all catagen hairs, and that again is a feature of both alopecia areata and syphilis. Pigment casts in the follicular channel can be a feature of both alopecia areata and syphilis. One thing that AA does that syphilis does not do is this dilatation of the follicular infundibulum, which in horizontal sections looks kind of like Swiss cheese, and Lila El-Shabrawi in Graz, Austria, has called it the Swiss cheese sign in transverse horizontal sections. So that kind of dilatation of the follicular ostia is characteristic of alopecia areata, not so characteristic of syphilis. So that helps, that this is more likely AA than syphilis. But the eos in the infiltrate, the pigment incontinence, anything AA can do, syphilis can do. The dilatation of the follicular ostia goes a little more with chronicity and is a little more of an AA feature than a syphilis feature. So that's potentially helpful. But that's certainly your differential. Those two.
Okay. Is there some pigment cast and some?
There are pigment casts. So when we talk about pigment incontinence in fibrous tract remnant in alopecia areata, we're talking about down here, right? Okay. Down in the fibrous tract remnant. This is a pigment cast being spit up through the follicular channel. And name three things that spit pigment casts.
It's trichotillomania, alopecia areata, and syphilis.
Yeah, because anything AA can do, syphilis can do, right? So trichotil, alopecia areata, and syphilis. You also see, tell me about this twisty-turny little hair that's all full of little dead reds.
So trichomalacia? Or
no, that's just catagen.
Okay.
So multiple catagen hairs you also get in those same three, right? So the pigment casts and the multiple catagen hairs, both of those go with alopecia areata, syphilis, trichotillomania. If you see true trichomalacia, that goes much more with trichotillomania, and in this case, you do have not just pigment cast, but you have a whole hair shaft that's kind of turned to jelly here, and that's trichomalacia, right? So when you see that, then you're more confident that you can rule out alopecia areata and syphilis, and it's probably trichotillomania. But the hair casts, the multiple catagen hairs, those are shared. And because they're shared, you look for things like deep pigment incontinence, EOs in the fibrous tract remnant, Swiss cheese dilatation of the follicular ostia, all of the soft signs of alopecia areata or syphilis. Anytime you say A, you have to whisper or syphilis. Okay. So how about this?
So here we see infiltrate in the eccrine coils.
The eccrine coil, and what
Infiltrate
kind of
consists of-
infiltrate?
It's neutrophilic infiltrate.
So, do you know anything that causes neutrophilic eccrine hidradenitis?
Neutrophilic.
Oh, yeah, neutrophilic eccrine hidradenitis. So, give me 2 causes of neutrophilic eccrine hidradenitis. Okay, you're blanking. Okay, so anyone give me 2 causes of neutrophilic eccrine hidradenitis.
Chemo. For
So
them.
chemo would be one. That's the one we think of most commonly, right? Someone who's been on 5-fluorouracil, Ara-C, cytarabine. Those are things that very commonly will cause a neutrophilic eccrine hidradenitis. There are also drugs that can cause toxic erythema of chemo. There's a lot of overlap in those lists. So that's number 1. Give me another.
Leukemia.
So leukemia by itself, where it's almost like deep sweets, deep eccrine sweets. So you can get it from the leukemia itself without the chemo. And then one more. How about a kid with sweaty socks? Pseudomonas hot foot. So kids with tender feet after they've been in sweaty, wet, can be perniosis in kids, right? But it can also be Pseudomonas hot foot, and Pseudomonas hot foot is going to show a suppurative hidradenitis. Very good. Okay, we got another hair shaft. Tell me about this, since you are the king of hair shafts.
Yeah. This looks like there's clumped melanin and beaded hair shaft.
So that is actually airspace, which you tend to get in medulla, and what it tells you is your medulla is discontinuous, right? It's there, it's gone, it's there, it's gone, it's there, it's gone, and you definitely have beading of the hair shaft, and when you turn down your condenser, you can probably make out that the hair cuticle is maintained. See this white area, kind of clear, transparent. The cuticle is nice and intact in the internodes, but worn away at the node. All of that being characteristic of
Manilothrix?
Manilothrix. Very good. And then Manilothrix can be syndromal or non-syndromal by itself. Okay, we've been looking at small biopsies. This is a big biopsy, right? And what do you see?
I see inflammation around hair follicle.
Inflammation around the hair follicle that's lymphoid suppurative and granulomatous. And what else do you see?
Like free hair shafts.
Free hair shafts, and they're straight up and down, right?
No, they're both like horizontally and perpendicular.
Yeah, ingrown and twisted, curled, right? So you got curled free hair shafts with granulomatous reaction, lots of free hair shafts, right?
acne keloidalis nuchae.
And then you got lots of hypertrophic scar, right? So where's the keloid in acne keloidalis?
In the biopsy site or in
In
the
the
person?
name,
Oh, okay.
not in the tissue,
I was like,
right? There's no. It's a misnomer, right?
Okay.
There's no keloid in acne
Just scar.
keloidalis. There's hypertrophic scar in acne keloidalis, right? So you see hypertrophic scar, ingrown hairs, suppurative process, and then often there are many plasma cells in the infiltrate, which is just a clue to it being nape of the neck, right? One of those plasma cell mecarinocytes. There are people who get bumps on the back of their head, just like pseudofolliculitis barbae, and no progressive alopecia. Those are just ingrown hairs. Then there are the people who get really progressive alopecia with it, and they're behaving like folliculitis decalvans, and you treat them like folliculitis decalvans. Okay. Which is the topic of another lecture, right? Okay.
Alright. So got a punch.
So first off,
It's like a
it
telogen.
shows you very nicely that's a telogen
Yes.
and that's an anagen,
Yes.
right? So you have the anagen has the entire hair. It's a very short, thick, stout anagen hair, so we're probably on the beard. So, probably a guy, beard area, to have short, thick hairs like that, right? And then you have a telogen hair right here where you have that kind of flamethrower appearance because of the tricholimal keratin that outlines the non-pigmented club hair. And then this one is just starting to grow a new anagen again. You got your little bulb starting to form there. And then,
Is it a catagen?
so you've got catagen hair, and you have numerous catagen hair, and you got a little pigment down here and a few inflammatory cells. So what might have been going on in the beard area?
So it could have been picking at it like trichotillomania,
Could have been trichotillomania of the beard area, or could be
alopecia or syphilis.
alopecia areata or syphilis. I mean, that's kind of your differential with that. Okay, how about this?
Looks like a scar alopecia
And
and interface change in
interface change in a vertical column of lymphs in the dermis, in the mid-dermis, and follicular plugging.
LE.
Yeah, so this is lupus, right? Vertical column of lymphs, mid-dermis, mucin in the dermis, follicular plugging, interface dermatitis.
So, a lot of lymphoid infiltrate.
I heard the words a lot of lymphoid infiltrate.
Oh, those are EOs. It's
EOs and
neutrophils.
neutrophils and granuloma. So it's a suppurative and granulomatous folliculitis with EOs. So give me a differential of a suppurative and granulomatous folliculitis with EOs.
So could be folliculitis decalvans.
It sure could. Folliculitis decalvans and alopecia areata both love to have EOs in them. Fungal alopecia also likes to have EOs, right? So could this be fungal? I don't see anything in this hair shaft, but I'll certainly look at the others for the possibility of fungal folliculitis. Usually if you have a nice hair shaft there, you'd expect to see the fungus in it, right? So fungal becomes less likely just because we see the hair shaft, even though that can do suppurative and granulomatous with EOs. Folliculitis decalvans absolutely can. The suppurative is the primary part of that process, suppurative with occasional EOs. And then the granuloma happens just when you have exposed hair shaft, right? It's like you got a splinter in the skin and you're going to get granuloma around it. So those would be big causes. You could get it, those are probably the biggest drug-induced suppurative folliculitis, maybe. That's a lot of exposed hair shaft for that. So folliculitis decalvans would be pretty high on your list. shows up with crops of pustules, those epilate. Then you get a donut of pustules, those epilate. Then another bigger donut of pustules, those epilate.
It's a pretty dense infiltrate. Seems like around the infundibulum and kind of in between the hair follicles as well.
And a big crust.
Big crust. Not as much going down the LPP, or let's see. Yeah, there's a lot of tagging, like epidermotropism of the actual.
There's a lot of follicular tropism.
Like
And let's go back to our basic rules for interface dermatitis. Is this holes out of proportion to lymphs, or is this a lymph in every hole?
Lymph in every hole.
So tell me something that beats on the follicle with a lymph in every hole.
So follicular tropic MF.
That's about the only one I can think of, right? So you got a lymph in every hole beating on the follicle. That's pretty much follicular tropic MF. And you may not see a whole lot of atypia at this point. Doesn't matter. I can't think of a lot of other things that really beat on the follicle with a lot of follicular tropism and a lymph in every hole. Okay, so this we're going to look at just because it's normal, right? So this is what normal elastic looks like in normal skin. It's a three-dimensional network that you have just cut in 2 dimensions, and you're looking at it in 2 dimensions. So they are going to look like pieces of that three-dimensional network, right? So if I had a nickel for every time an article had an elastic stain and they talk about fragmented elastic fibers and they show you perfectly normal elastic, that's what normal looks like. So how do you know when it's really broken? Well, one is when you are at the top, it breaks up into a very fine candelabra, right? They become more and more delicate, but they go all the way to the surface, right? That's normal. You would have some areas of complete loss, and then because these are stretched out rubber bands, if a rubber band is snipped, it becomes short and thick when it recoils, right? So you're looking for evidence of recoil in a scarring alopecia. So this is normal, right? That's what normal looks like. Okay, so then we're going to look at abnormal. So here's a pattern of abnormal. So what's wrong here? Too little or too much elastic?
Too much elastic.
Too much elastic. Looks like solar elastosis, right? Which means, why is so much sun getting to that scalp?
It's bald.
Because you're bald, right? Because you're a bald golfer who doesn't wear a hat when you go out, right? And then you have normal fibrous tracts that are not scarred. This shows you the normal elastic sheath. So around hair follicles, you normally have a very thick sheath of elastic fibers. And this shows you how they kind of condense into a sheath around that kind of lines the outside of the hair follicle. When the hair has involuted, that sheath remains like a sock without the foot in it, right? And damage to that sheath is evidence of a scarring alopecia. It also shows you what normal fibrous tract remnants look like. So where the hair used to be, let's find there's a perfect one right in the middle. So this is the empty sock without the foot, right? You still see the elastic sheath on the outside, and the foot was pulled out of the sock, but the sock's still sitting there, right? That's what a fibrous tract remnant, or you'll hear the term stela, S-T-E-L-E, stela, or some people pronounce it steel. was the column of stones that the Roman legions erected to a fallen soldier. So these are supposed to be, the little monuments of the fallen hairs, right? So that's where that term comes from. But it's, the foot is no longer in the sock, but the sock remains, is basically the idea. But that's what a totally normal fibrous tract remnant looks like. There's nothing wrong with it, right? It has normal vascularity, the blood vessels are there. That's normal.
That's going to be like between telogen and
Yeah,
anagen.
between anagen or
Just-
telogen, or in an involutional pattern alopecia, where the hairs just peter out, but there never was inflammation there, right? And so there's nothing that ever damaged those fibrous tract remnants. Okay, now let's look at this one. So the deep part of the fibrous tract remnant. Whose turn are we on?
It's my turn.
Okay. Very good of you to admit that. So you got a heavy elastic sheath on the outside, right? That's all normal. Where'd it go?
Wedge shape.
Yeah, you got a wedge-shaped scar. And not only do you have a wedge-shaped scar, but you can see what normal elastic fibers look like, right? So if that's normal, why are these so thick up here? Because they're recoiled where they were snipped, right? So that happens on the edge of where the scar is, and then the scar itself is a superficial wedge. So tell me two things this could be.
LPP or folliculitis decalvin.
Yeah, LPP or folliculitis decalvans. One's lymphoid and beats on the follicular infundibulum. The other one is suppurative and beats on the follicular infundibulum. So if you look at the patient, there are a number of clues. One is he could have crops of pustules. I'm thinking that one's folliculitis decalvans. Or he could have little doublets of hairs and silver spines at the base. That's LPP, right? Suppurative processes tend to give you six-pack clusters of hairs, tufts, whereas LPP tends to give you doublets. And the follicular spines are a feature of LPP. So putting it together with the clinical, you often get a diagnosis, right? So in this case, there's no inflammation. On biopsy, these are often read as nonspecific, but you throw an elastic on there and you see the footprint of where the inflammation was, right? So we're all socks and footprints, right?
Bless you.
That's what it's all about. If I can get the next one out of the box. Good grief. It's like glued in there. Here we go. So what's going on there?
Looks like you've got multiple hairs.
And are they big strapping terminal hairs or are they little vellus hairs?
They look like vellus hairs.
Little vellus hairs with a non-pigmented bulb, right? So little telogen vellus hairs. And what are they stuck in? A keratin plug, you're right.
Okay.
So they are stuck in a keratin plug, lots of little vellus hairs, and they would have stuck up here looking almost like a spiky comedone. So what is this? You want
not
to
sure, telogen
jump in?
Trichostasis spinulosa.
Trichostasis spinulosa.
Okay.
So if you pull out those plugs in trichostasis spinulosa, you guys know what a Biore strip is?
Yeah.
Yeah.
Pore strips.
Yeah, pore strips.
Is that what it does?
And so that's the best way to treat trichostasis spinulosa, right? And when you pull it out and you got all those black plugs, that's what they look like. Okay. Okay, what you got here? So first off, did this fall out or was that cut?
That was cut.
How about the other end? Did that fall out or was that cut?
I think that one fell out.
No, it was cut too,
Okay.
right? So that means the hair wasn't falling out. We just cut a sample of it because it's cut on both ends, right? So this is probably not something where hair is falling out and not something with hair fragility because it was cut at both ends. And then you look in the middle and what are you seeing? And sorry for those online, it's not projecting really well. But
darker pigment in the center of the hair.
and it's not pigment, it's airspace.
Airspace.
Right? So airspace, lack of airspace, airspace, lack of airspace, airspace, lack of airspace. What's that?
I'm not sure.
Anyone?
Is that spangled hair?
Yes, spangled hair, which is also called annulati. Correct. And it's the only hair abnormality that people like because your hair is sparkly.
Okay.
And so I've diagnosed probably, 3-4 families with polyannulati, and the story's always the same. The whole family's there to show you their beautiful hair, and they have poor little Jimmy who's got this dull hair, and they want to know what's wrong with Jimmy's hair. Jimmy is the only normal one in the family, right? But the patients like that lustrous, sparkly hair, and so they want to know what's wrong with Jimmy. And his name's always Jimmy for some reason. Okay.
Okay. So we have another hair shaft with looks like a frayed end.
A frayed end. And so that goes with what? Like a brush fracture or broomstick-like fracture. You are correct, T. nodosa. And trichorexis nodosa can be wear and tear,
Okay.
right? We see it very commonly in black patients who have overprocessed hair and the hair becomes fragile, right? Anything inherited that has T. nodosa? Anyone want to jump in?
There's like a bunch of syndromes, right? Like
There are-
Mickey's can do it. or-
Menkes can have it, but
Yeah.
what's the more characteristic abnormality in Menkes?
Yes, the other one.
The other one, which is pileotorti,
Polytorty.
right? Menkes is can actually get some T. nodosa, but the most characteristic is pileotorti. T. nodosa is most characteristic for genoderms of arginosuccinic aciduria.
Urea cycle.
Yeah. Okay. Do our next one. And it's a hair shaft.
This hair shaft seems without pigment.
So it's a hair shaft without pigment. And another one. And then what happened?
Bubble.
Bubble hair,
Yeah.
which in the South we call bubba hair. So bubble hair, what causes bubble hair? Is this some kind of amino aciduria?
I don't know.
It's like this heat, right?
Yeah, so it's your blow dryer is shorting out, and instead of being red hot, the element is white hot, and you're turning your hair into popcorn.
Well, that's somebody with really white bleached hair, perhaps.
Oh, and this one would have been someone with pretty blonde hair.
Hold on.
It's like a kind of sparse lymphoid from
Yeah, so sparse lymphoid infiltrate, kind of around the, what part? Pretty high,
Yeah, I'm not
right?
sure. Yeah.
And there's spongiosis with it. That's usually just sebderm.
Okay.
So when you have a spongiotic infundibular folliculitis with some lymphs, that's just seborrheic dermatitis. When you're up towards the surface, you might have a little scale crust by the follicular ostia, but that's sebderm. And you commonly see it as a background in alopecia biopsies. So it usually doesn't mean much other than the guy needs a little Selsun, right? So what else do you have going on? Are the hair shafts all the same size?
No.
And the follicles are not the same size, so Yes, so you got anisotrichosis, and you got lots of fibrous tract remnants. And in those fibrous tract remnants, are they scarred, or do you have normal vascularity?
Normal vascularity.
And a normal elastic sheath around it, right? Do you see eos? Do you see lymphs? Do you see pigment?
No.
Nothing, right? They're just lots of normal fibrous tracts. And so what's your differential?
It's a non-scarring, non-inflammatory.
Non-scarring, non-inflammatory alopecia with variation in hair
Pattern.
so patterns most likely, right? You'd look for other signs of alopecia areata. So we had the benefit of having a vertical section, right? So do you see any Swiss cheese dilatation of the infundibulum?
No.
Not so much, right? So, I mean, it's really starting to look like pattern in someone who's got a little subderm too, right? Where people get hung up is that little bit of lymphoid inflammation that they want to call it an inflammatory alopecia, right? That's just subderm background. Okay, so that's those. Let's do a little bit of lightning rounds. Right? How are we doing time-wise? Time. We're not going to get to potpourri, but the alopecia takes a little longer than some of the others. Okay.
Just got an ET page, so if I go over there.
Oh, sure.
Yep.
Okay, so David, something totally different in the adnexal category. Where are we?
Mucosal.
Mucosal. And what are these things on the mucosa?
These like kind of ectopic sebaceous.
Are not sebaceous, but minor salivary glands, right?
Minor
So those are the normal minor salivary glands. And are they happy minor salivary glands?
They're pretty inflamed.
Do you have big lymphoepithelial islands?
Yes.
And do you have multiple large aggregates with more than 50 lymphocytes?
They're Sjogren's.
So this is Sjogren's, right? And so biopsy for Sjogren's is one of the things that we do, right? It's also one of the things that dermatologists do get sued for because they cut the mental nerve, so you don't want to do that, right? So put your tongue right in the middle of your bottom lip, and you don't feel much. Now put it right there on the side and right there on the side on your bottom lip, and you feel all that tapioca. That's where your minor salivary glands live. That's also where your mental nerve comes out, right? So where do mucoceles occur? Right there, right? Because it's where all the minor salivary glands are and where you bite your lip, right? Working on a mucocele, doing a salivary gland biopsy, you never snip. You never snip. What do you never do?
Sniff.
Correct. You spread, so you just make an incision there, right? You don't have to cut a wedge out. Just make an incision. You go in with your Gradles or iris scissors and you just spread, and then you squeeze and out pop little round things. Those are the minor salivary glands. You just drop them in a bottle. What do you never do? Snip. Correct, because you can leave someone with permanent numbness there. Okay. Okay. Probably not the best example. Let's do this. I'm not sure that one's fair either. Let's skip it. Let's go to... Okay. So, what kind of stain is this? Elastic stain, right? So, you see all your black elastic fibers there. In this case, they're a little more gray than black. And you're going along the surface, and then you hit areas where you kind of lose your black. So see your elastic sheath.
Mm-hmm.
See how it kind of ends here. Is it ending deep or ending high?
Ending high.
ending high, right? And you got some recoil of elastic fibers next to it. And you've got some not only follicular dilatation, but they kind of stick up a little bit, like maybe you had a spine there. You can make it out here in this one. So what's going to give you this pattern?
LPP.
Yeah. So that's lichen planopilaris. Well done.
Alright, so looks like not a ton of inflammation. Lymphoid.
Yeah. Where are your hairs?
Pilosebaceous units. Hairs are absent.
But your
Or
follicles are
digitally.
there, right? They're just converted to sebaceous follicles. So what kind of alopecia do the hairs have become? Tiny, tiny little vellus hairs, and the follicles have just kind of converted to sebaceous.
I'm not sure.
Kind of,
Pattern? Or
yeah, end-stage pattern.
Okay.
And so everyone at birth gets dealt a hand of cards, right? Each one is a hair cycle. When those cards are used up, then you're bald, right? Some of us were dealt more cards. Some of us were dealt fewer cards, right? The people with fewer cards are going to get bald after they've used up those hair cycles, right? That's early onset pattern alopecia. People who have, if you have twins and one of them has had serious illness and the other one hasn't, the twin with serious illness is going to have early onset alopecia much, much younger than his twin, because every time he's had a telogen effluvium, he's used up a hair cycle, right? The other thing you see is you have some people who've had chemotherapy who just don't regrow their hair after chemo. And they've basically just used up their hair cycles in the process of the chemo. And so this is someone with hair that's just not regrowing after many cycles, complicated course of cancer and many cycles of chemo. And it's just kind of exhaustion of your stem cells, and the hair just involutes to a sebaceous follicle, and you're not growing terminal hairs anymore.
And you don't have any fibrous tracts at that point. They kind of
Oh,
just go away.
they're there. They're not real prominent in this particular example, but if you stain, there are fibrous tracts under here.
Okay.
They're just skinny. They're not scarred. They'd show up with an elastic stain. Got 10 minutes remaining. Let's do. And we're trying to hit some things that were not hit in what we just did, right?
So there's a central ulceration,
Yeah.
with
So
crust.
like a crust, ulcer. What's under the ulcer?
maybe like some fibrin or
And what's on either side of the fibrin?
granulation tissue.
So what is this?
CNH.
CNH. Very good. Skin.
Yes.
And what's down here?
Is that cartilage? or-
Cartilage. Is it happy cartilage?
No.
It's unhappy cartilage, right?
Yes.
And it's unhappy and kind of degenerated down to jelly right in the middle.
Mhm.
And here you're just seeing the top half of what should be cartilage, and then it kind of fell apart at the bottom. So what are we looking at?
CNH. Or
Not CNH, but auricular pseudocyst. Right? Boxer's ear. you've got hitting the side of the head, and you've got a degeneration or hemorrhage in the middle of the cartilage that splits the cartilage into two leaves.
You should call it cauliflower ear in wrestling.
Yeah, cauliflower ear, exactly. Boxers, wrestlers.
Or your headgear.
That's why you wear your headgear. That is correct. Okay. That's not fair. We're not going to do that. Let's get another here. Okay, here's a good one. And then okay, so where do you think you are?
Mucosa.
Mucosa, and what's this down here?
That it was
And then what's that up above it?
mucosia.
A big mucosal. Right, so you've got your minor salivary gland, and then you've got where your duct got ruptured or bitten. And then you've got a huge collection of mucin with palisading granuloma and inflammatory cells around it. Right, so that's a mucosal.
An inflammatory infiltrate, trying
Yeah.
to decide what's in it.
So
That one looks separate.
looks separative.
Is that fungus within the hair?
Sure is. Right. So separative folliculitis, separative and granulomatous, among other things, you look for what's in the hair shaft, right? So that's tinea. Okay, and we'll end on this one. So that's normal scalp, right?
Mhm.
And then this over here, you have complete loss of hair follicles, you've got hyperkeratosis, acanthosis, hypergranulosis, a big scarred area. Right. And so the question, this was done, so the history was, it was a young woman in a car accident, and she was in shock, and so they gave her lots of vasopressin, and that caused lots of vasoconstriction, and she has vasopressin-induced scalp necrosis. So this is one of many scouting biopsies, because they're getting ready to do surgery, scalp reductions, and they don't want to cut out areas where she could regrow hair on her own, right? So she wants it all fixed yesterday, but they're trying to tell her, you know, some of these areas you're going to regrow hair, you don't want to jump the gun and cut out areas that can regrow hair. So how are you going to know if this area is going to regrow hair?
Do elastin stain.
Do an elastic stain, and what are you looking for?
Looking for loss of elastin.
Loss of elastin,
the
which
level
would be
of the
scar, and
Yes.
you're looking at where the level is, right? So what this little structure there, hanging off of it, and here, that's the bulge, right? The bulge is around the area of the erector pili insertion. That's where your stem cells reside that are going to give rise to a new follicle. Scar at that level means you're not capable of regrowing hair. If that level is not scarred, you may be capable of regrowing hair. So most of the scalp biopsies we look at are diagnostic. This one's prognostic for ability to grow hair after scarring. And actually, her level of scar when you threw an elastic on this was like right here. If you drew a line right next to that bulge, right across, it was right there.
So you said maybe.
That was a solid maybe. Exactly. And she actually waited and she regrew the bulk of her hair without surgery.
Oh, nice.
So, and that's it for today.
Thank you.
Thank you.
That was easy.
Well done.
I have a question for you. So